All right, so is it really March 2nd already? It is really March 2nd already. I'm not sure where 2020 went, but it can stay wherever it was, but it seems like 2021 is just going by way too quickly. Today in special topics, we are going to talk about obstetrics, being pregnant women, and then also the incontinent patients. So patients with pelvic floor issues. So that's the topics for today. We will get out all our giggles right now. Hee hee hee, ha ha ha. We're gonna say words that make us giggle. Hee hee hee. All right, we're done with that. It's not a laughing matter to some of these people, and sometimes the laughing matter actually causes some of these problems. So we have to be consciously aware of that. So when we're talking about whether we're talking about pregnant patients or whether we're talking about incontinent patients, the anatomy itself is the same. For the most part, the male and female anatomy all lays out essentially the same, right? We have our main bones surrounding our pelvic compartment being our two oscoxae, right? We have our sacrum, we have the lower portions of our lumbar vertebrae, and we have our big hip bones, right? Our parts of our femur. That's kind of the surrounding cup, if you will, that holds all of our reproductive health, our pelvic health, everything like that. Now, when you're looking at it from a pure anatomy standpoint, the main thing that you notice if you look at this is there are a lot of ligaments in there. Well, why is that? Well, we've got a lot of important weight-bearing structures. And I've talked about it before when I mentioned about patients that like have Duchenne's muscular dystrophy and sometimes even patients that are Down syndrome, that they hang on their ligaments when they stand up. And what hanging on the ligaments literally means is they have all these ligaments in the pelvis, and rather than using active muscles of the hip to hold the person upright, they kind of relax the muscles and just let the tension of those ligaments hold them upright. And it can do that for a time, but we know that ligaments are subjective to stresses and can actually rip and tear and everything like that. Now, if you ask most pelvic floor specialists, most of these ligaments can be stretched and can be mobilized in some way. Some of them a little bit harder than others. Like the sacrotuberous ligament is a very, very difficult ligament to get any stretch going on because the sacrum has very, very, very little mobility in it, right? It's designed to be kind of a fixed bone, but there are ways to stretch it. The one thing that I find that a lot of clinicians miss, and this is even with low back pain, is a lot of clinicians that are treating low back pain ignore this muscle right here, the obturator. And why I say this is there's a study done, I want to say it was 2012 or 2013, where they reviewed people presenting with low back pain and sciatica that were diagnosed as sciatica or lumbalgia, right? Low back pain. That turned out it wasn't even low back pain, it was a tight obturator muscle that they stretched the hip into external rotation, and magically the patient's pain got better. Or they did dry needling of the obturator, which, look at this real quick and think of what dry needling of the obturator probably feels like. That's a pretty long needle because you're going to have to go in through the backside and go through all of the muscles of the piriformis and gluteus maximus to get to obturator. But they found that if they did dry needling of the obturator, it actually relieved the patient's low back pain. Well, why do you think obturator will be playing a part into low back pain? Does anyone have an idea? First of all, you guys do know that obturator is the muscle you have in your hip. Yes, I'm assuming. I just want to make sure that we've got that much at least, that I'm not making muscles up. Okay, that's good. I once had a group that I was talking about this. I think it was cohort 4 or 5. I can't remember. And they're like, we have a muscle called obturator. Here's magic. We have a nerve called it too, and a foramen. Guess what goes through the foramen? Go figure. So all these muscles, when you look at them, all the muscles and the ligaments form this almost sling in our pelvis, right? So they form what I call the basket. What's going to sit in that? It's weak if you might lean forward. You're absolutely right. Yep, 100%, right? So you lean forward a little bit. The other thing is you're going to be kind of forced into that internal rotation. And if you force into that internal rotation, you're going to put a lot of strain on that back side of the back, right? And it's going to pull. And when it pulls, it's going to pull down on all those nerves that are right there in your butt. And man, now magically you get a tight piriformis. Now you get a tight sciatic, right? Maybe we're stretching the piriformis like crazy, thinking it's a piriformis issue. Well, what's causing the piriformis issue might be obturator. So if we stretch piriformis, we might not get the obturator. So there are theories here for it. Like I said, this forms a sling, right? This bread basket down there. What's going to sit in that bread basket organ-wise? The reproductive system, right? Most of the reproductive system for females, yes, right? The reproductive system for the males sits externally for the most part, right? Why does that happen? Why is females' reproductive organs inside and males' reproductive outside? That seems a little counterintuitive, doesn't it? Well, pregnancy is part of it, good, right? Yeah, because you guys have to give birth. Does anyone know why the organs are separate? Did you learn that in anatomy? Well, because the male reproductive organs have to be at a lower temperature than females. Yeah, warmth, right? Your eggs and your follicles and that of your female reproductive system like to be at body temperature. Whereas, males, sperm, stuff like that, do not like being at body temperature. When they're actually at body temperature, they die off, right? When I was first coming up through the IT industry, there was a joke that if you used a laptop on your lap, you were going to go sterile. And that was because back when I came up, laptops were these big honking 4,000-pound things that turned into mini thermonuclear heaters. And the thought was, well, it's releasing radiation. Well, technically it is. It's radiating with heat. And they're not wrong that theoretically, if you kept that laptop on your lap long enough, you were technically killing off sperm. Now, not to an appreciable, number that you could say, well, you can't get anyone pregnant if you have a laptop on your lap, because the male reproductive system produces sperm quite rapidly as long as you have a healthy system. But that's part of the reason, right? The other reason is baby, right? Baby's got to stay, plan A. Baby's got to stay inside mom in order to be protected. It would be really awkward for mom if she was carrying baby outside of her uterus, wouldn't it? Like if suddenly mom grew a scrotum and was carrying baby outside, that would be really awkward for mom. And now you're all visualizing it and going, yeah, that would be awkward. So we've got the reproductive organs. We've also got all of our organs of urination, right? We have our bladder, we have your urethra, all that stuff inside that pelvic sling. It's not a very big area. So that means, if something gets damaged in there, it's going to have a cascading effect. Or if you get pregnant, right? When, whatever you want to say, you get pregnant, baby has a nasty habit of ruining everything inside there for you. Because again, babies are little parasites, and not only they're parasites, but they like to kick, scream, roll over, do all kinds of fun stuff like that, that destroys the inside of a female anatomy. Babies are little terrorists on mom's bodies, right? It's very common for mom when they're pregnant to get sciatica, to get obturator nerve problems. Well, why is that? Well, baby's pressing down on those nerves. There's not a ton of room. So all of this comes into play, whether we're talking about babies or whether we're talking about public health. And so now if I put a lot of downward force on this sling, right, I'm also going to put a lot of downward force back here on the levator ani and coccygeus muscles, and also my external anal sphincter, which could lead to problems not only with urinary incontinence, but potentially fecal incontinence. So here's kind of looking at it in an anatomical model. I was told we don't need this anatomical model when I can just use pictures. So there's the picture of it. But you can see how it kind of forms a sling in there. So we're going to understand the objectives here, looking at the physiological impact of pregnancy on the body system, examine some exercises, identify some precautions and contraindications, describe pathologies and interventions unique to genitourinary function, including pelvic health, right? So let's talk about mom gets pregnant. Mom gets pregnant. What happens to her body? Well, I'm sure that several of you that are moms in here will say that at least for the time being that they were pregnant, the baby basically destroyed their body. Would you guys agree with that? You may love your kid, but your kid probably did some mean things to you while they were in utero. Yeah, right? It was definitely not all candy canes and sugar pops. They did some nasty things to you. Average weight gain for a female is 25 to 35 pounds. Now, some of you, as soon as I say that, are going to go, well, I gained way more than that. And that happens. You've got to figure that's average weight gain is 25 to 35 pounds. Means that there are some people who gain a lot less than that, right? There are some moms that, for whatever reason, are super lucky and they gain just baby weight, right? So they gain the whatever it is that baby is. In the case of my mom, for those of you that really want to cringe and kind of be scared, when I was born, I was 12 pounds, 8 ounces. So I was a very, very, very large 1-year-old when I was born. And my older brother was 12'10". So big babies, right? And big babies like that are very destructive on mom. I caused my mom to have to spend, I think it was 4 weeks in the hospital because I actually caused her to bleed out. Yeah. And my mom wasn't much bigger than you, Jesse, just to let you know. So you can imagine what that did to her human anatomy. Yeah. So all the ligaments connected to the pelvic floor organ increase fibroelastic properties more than musculoskeletal ligaments in general. It allows them to stretch easier. So they are greatly more elastic than any other ligament in our body. And I kind of look at this going, it'd be really interesting if we can find out why these ligaments are more elastic, because maybe there's some secret in them that we could use on other ligaments that are getting damaged, right? If we know that the ligaments of our pelvis are more elastic than any other ligament in the body, maybe we can use that to help treat patients that have ACL tears and stuff like that. Just kind of a thought process I thought when I was going through this. The kidneys themselves increase in length about 1 centimeter, and 1 centimeter doesn't sound like a lot, but in the human body, that's a huge difference in an organ. The ureter's angle in relation to the bladder changes. It becomes perpendicular, which can lead to the risks of UTIs due to urinary stasis. It gets harder for mom to go to the bathroom, and it also leads to mom having frequent trips to the bathroom, right? It's, it's a joke when we're in physical therapy is a lot of the moms that come in for physical therapy that are pregnant, they're going to go to the bathroom 9 times while they're in physical therapy because they're moving around a lot more. And so that urinary stasis they're having from normal baby is getting moved around. So they go pee a lot more, right? One of the first things I usually do with my obstetric patients when I have them is I say, hey, why don't you go to the bathroom quick before we start therapy? Because that way, at least I can get some of that urine out. And so it takes care of it. Hormonal changes can lead to edema and tissue congestion of the upper respiratory tract with increased respiratory secretions due to hormonal changes. It's not uncommon for mom to get some sort of a respiratory dysfunction while she has baby, whether it's, allergies, whether it's a stuffed nose, whether it's congestion in the chest, all that can happen. The ribs change. They flare up and out, resulting in increased chest circumference. And the interesting thing here is because the ligaments in the chest and the tendons in the chest aren't as elastic as the pelvis, those ribs may not return to normal, meaning that mom may end up after baby's born having a wider or larger chest circumference, meaning that clothes don't fit right after baby. And even after maybe they lose baby weight, clothes still won't fit right because their chest is actually kind of expanded slightly. And, that adds all kinds of other things. the diaphragm itself gets elevated. Well, why is it elevate? The diaphragm going to elevate? Well, you got to make room for baby down here. So diaphragm's going to elevate. It's going to progress through pregnancy until the last few weeks when the baby drops down into the pelvis before delivery. And that's a common term you'll hear in a lot of TV shows, right? The baby's dropped. It's getting ready to crown. Like they have any idea what they're talking about in those TV shows, but when the baby drops, it's going to cause all kinds of different problems. The depth of respiration is going to increase, tidal volume is going to increase, but total lung capacity is unchanged, if not slightly decreased because the diaphragm gets elevated. So that means that overall, work of respiration, right? The work of breathing is going to increase because mom now has to breathe for two. And they're going to actually hyperventilate, meaning usually your respirate's going to change as a mom. You're going to consume about 15-20% more oxygen. That makes sense. Baby is about 15-20% of your size, so you're probably consuming a little bit more. Dyspnea, shortness of breath, is often noted with even mild exercise starting about midterm, 20 weeks. Did any of you moms experience that? When you had baby, that you got short of breath really easy? That you felt like you just couldn't do the things you normally do because you just felt, God, that wiped me out. Upstairs, yeah. Right, that's usually what I hear is, my bedroom's on the second floor and just going up to go to bed is miserable. I've had to put a chair on the landing so that I don't get too exhausted going upstairs, right? Well, why? Well, work of breathing, right? But you're also now moving 35 pounds more upstairs. There was one, it was funny. I had one mom once in the clinic that her husband wasn't getting what she was going through. So for 2 weeks, she made him wear a 35-pound weight vest, just so that he could feel what she was feeling on his, and he finally got why she was so tired and why she was so sore by adding that 35-pound weight vest to his daily activities. It's like, oh, now I understand it. I thought that was a pretty good experiment on her part, and I guess he learned his lesson. I don't know that I participate. I'm already heavy enough. Your blood volume itself is going to increase by up to 50%, mainly plasma due to physiological anemia, but the blood volume itself is going to increase because you need to provide for baby. Venous pressure in the lower extremities increases in standing. It's harder to get the blood back from the legs in standing. The inferior vena cava, so that means one of those main vessels coming back to the heart, pressure increases. And along with that pressure increasing, it can cause aortic occlusion in supine or right sideline. So if your boards ask you a question about what position to not treat a patient in, the number one position you do not treat pregnant patients in is right sideline. Because if I lay on my right, I'm pressing down, my vena cava is going to press down on, it's going to occlude my aorta, and I'm going to end up with problems. Left sideline creates the least amount of aortic occlusion. So that means that's a fairly safe method. Blood pressure will vary entirely through the pregnancy. First few weeks being its lowest, then midterm, and then it gets by birth back to kind of pre-pregnancy levels. Now, asterisk here, because I've seen some moms that once they get baby, they have permanent hypertension, high blood pressure. And then I kind of question, is that from baby being born, or is it because they now have a baby and now they're stressed about everything, right? Especially if you're a new parent. From what I've seen, I cannot attest to this because I've never been a parent, and probably that's a blessing on the entire United States. But I can imagine what it would be like for somebody that's never had to take care of another object in their life to now have to take care of a living being, and how stressful that would feel. Other things happen. The heart enlarges. And because the diaphragm moves up, the heart's going to move up. Because the heart's moving up, it's going to kind of move more into that cardiac notch, which is going to give it a little less room. Some women may experience arrhythmias and changes in heart rhythms during pregnancy. Usually after I talk about all this stuff, any of the ladies in here that have never had a kid suddenly go, you know what, having a baby just doesn't sound that great anymore. Heart rate will increase by about 20 beats per minute by full term. Cardiac output increases by 30 to 60%. To me, this is pretty amazing. This says that mom's heart can pump 30 to 60% better, and it's designed to do that, right? Your heart is designed to be more full than our heart is as a male. Abdominal muscles are stretched to their limit by 40 weeks. At that point, when you hit 40 weeks, the belly is about as big as it can possibly get. And if it gets much bigger, problems are going to happen. In this stretched position, pregnant women have very poor contractibility, which means sitting up from any type of recumbent position or laying down is nearly impossible, right? You have no mechanical advantage of your abdomen to sit up. Some of us feel that way anyway with our big bellies, and we don't have that ability. But just imagine having that because of baby. Also with the shift in gravity, right? Anytime that a female kind of lays on her back with baby, now it's going to shift that weight back. It's a lot harder to get that inertia started and move. Ligaments have a direct degree of tensile strength due to hormonal changes, right? In the female body, relaxin gets secreted by the ovary, the placenta, and the breast. And that relaxin's job is exactly like it sounds. It relaxes the ligaments and muscles. Progesterone is also excreted from the ovary, placenta, and adrenal glands. In this case, joint hypermobility is a major problem, right? Making the patients more prone to ligamentous injury, especially the weight-bearing joints. This is why we don't want to do traction, like mechanical traction on a pregnant patient. Number one, it's probably not a good idea to put the belt on them. Just going to say it. Number two is, because of this relaxin, all those ligaments in the spine are also weakened. And you can actually damage the spine by putting them on. Does that mean we don't do traction on pregnant women? What do you think? Should we not do any traction on them at all? We don't do any joint distraction? It's strictly hard contraindicated. We can, right? Yeah, but you need to be trained on it. This is not something that like I would want a student doing. And I've had it where I've had a pregnant woman that we're doing low back traction on, and we're doing manual traction where we're actually kind of stretching at using the pelvis as our point to stretch at. I don't want my student doing that because you guys aren't trained in it. So if you're treating a pregnant woman or an obstetric patient, right, just be careful and make sure that you're just a little extra cautious. The pelvic floor will drop due to the weight of the uterus, and it can be stretched toward, excuse me, yawning too much today, or incised during delivery. That's where we get into this term episiotomy. And usually if you say this to any mom who's had a baby, this is the big scare that doctors talk about that you hope that you don't incur. Because an episiotomy is a tear to the actual external areas of the body, right? First degree tear is pretty common. That's just a minor skin tear. Second degree tear includes underlying muscle. A third degree tear extends all the way back from the vaginal opening to the anal sphincter, and may fourth degree tear go all the way into the rectum. That's bad. Baby can really do some pretty nasty things to you, right? The pudendal nerve, which is the main nerve of the perineum, can be stretched or compressed during delivery of babies, including by the baby's head during vaginal delivery. So this adds a question here that, a lot of people have asked in the past is, why are we still doing vaginal deliveries? Why don't we just do all C-sections? Wouldn't that prevent a lot of this? If we can do cesareans and just cut the baby out, wouldn't that make more sense? Or does that cause other problems? Right. C-section, we're now talking surgery, right? And then when we add surgery in, that adds existing complications. Now, is it preferable to losing the baby? Probably. Yeah, right. I say probably not in the negative term, just meaning it probably is. Your basal metabolic rate changes and your heat production increases, right? And this is really common for moms to say, I am just warm all the time. Or the other side of that is if they're in a colder environment, right? If you're in a colder environment, like I'm from Pennsylvania, because you're so warm, you're now freezing all the time. So it just depends upon what the exterior temperature is, but their body temperature itself increases. Posture imbalance changes happen. Shoulder girdle and upper back become rounded with scapular protraction. Upper extremities become internally rotated, right? Mom takes on that keyboard look. Now, let's think about nowadays. What's going to make this worse, this posture here for pregnant women? I'm going to play some Candy Crush with baby, right? Yeah, phone, even the desk jobs that we are in nowadays. We're already promoting this kind of posture, right? Now mom comes along, has baby, and baby forces her kind of more into this posture. Is that going to, and the cervical lordosis is going to increase up in the neck, right? Is that going to cause neck pain? Yeah, right? It's not uncommon for women with pregnancy that have neck pain. And also, if you have neck pain, right, two things usually come along with that: cervicogenic headaches and cervicogenic dizziness. So because that neck becomes all kind of stretched out and sore, it's not uncommon for our moms to get headaches from it. And it's not uncommon for them to get dizziness from it. Now you add in the hypotension because they have baby, and mom's kind of a hot mess. The lumbar lordosis is going to increase in order to provide for support for the back and carrying the baby. The weight is going to shift posterior to adjust the center of gravity, right? As my mom kind of gets that cowboy walk going on. And the funny thing about these postures is once the baby is born, so baby parasite is now ejected from the female body, childcare activities after birth don't exactly promote return to normal function, right? Changing a diaper, we're in this posture, right? Especially if you don't have a diaper table that's at height. We're getting better about that kind of stuff. I had a friend that recently had a child, and that was one of the things, and she's an OTA. That was one of the things she was requesting was she wanted specifically ergonomic baby stuff. Like the crib was ergonomic for getting the baby in and out. The changing table was ergonomic. And she was very much aware of posture because she didn't want to have her whole career ruined because of baby. It kind of makes sense. A little forward thinking can do some great things. But there's going to be increase in weight and redistribution of body mass due to the baby that the mom's going to have to compensate for, right? They're going to get a little bit more of that base of support width, again, the cowboy gait, and they're going to end up with a little bit more hip external rotation. And at that point, then again, we're back to, oh my God, look, obturator is now getting stretched. Another problem that happens pretty commonly is diastasis recti. What does diastasis recti mean? Diastasis recti. It literally means splitting of the rectus. So it's going to be rectus abdominal separation. So as baby comes out, that split in the middle of the belly gets larger and larger, right? And that can actually tear. So they can end up with the 22 centimeters is abnormal. So think about it. Up to 22 centimeters of splitting there is normal. Lord. And they should be tested. So a patient that's had, any type of baby, obstetric patient, before we start giving them an ab program, we should check their rectus abdominis to make sure it hasn't split. Because think about it. When my rectus abdominis is together, it's straight down my belly. If it splits, now my pull is different, right? So now it's out here kind of, right? And that means my pull is going to be totally different based upon the side. I'm almost going to get like, it splits the lineaspora. Yes, it does. Right? And that is a definite oof. You are right on that oof. Because the lineaspora is going to be the weakest point, right? That's going to be the weakest point of that muscle. Could it also cause possibly an umbilical hernia? What do you think? Yeah, right? It's not uncommon for mom to get all kinds of hernias after baby, right? Umbilical hernia, or what we call a sports hernia, right? Any type of, or a herniation of the abdomen up into the chest cavity as well. I've seen it where moms get some of the intestines pushed up in through the little split in the chest cavity and get intestinal hernias because of baby. Low back pain is common due to postural changes, right? Education and exercise are the best treatment, but don't do deep heat, e-stim, or traction on a pregnant woman. Let's think logically about this. Why do we not want to put heat on a pregnant mom's back? What are we literally creating? Yeah, we're cooking the baby. And think about this just from a logical standpoint for a second, right? Both heat and e-stim are energy increasing modalities. Now you've got baby inside belly that is differentiating, right? The cells are splitting and meiosis, mitosis are going on. And we know about cancer, right? Cancer, we know that if we add heat to it or add energy to it, it's going to further multiply. So could doing one of these modalities potentially cause some form of a birth defect? Theoretically, if you had to think about it, could it? Yeah, right? There's nothing that says it couldn't. So we got to think about that. And definitely we talk about traction because of the ligaments. But, and also just again, I saw somebody try to put a pregnant woman on traction once before, and I'm like, baby, strapping down, not good idea. And the PTA, I wasn't going to argue with them. Symptoms typically resolve postpartum if good mechanics are utilized, right? If mom gets the proper equipment, learns how to take care of baby with proper body mechanics, your low back pain can go away, right? But I'm going to admit most of the pregnant women that I've seen prepartum and then postpartum have the same symptoms. They come in with low back pain when they have baby. Once baby's born, they still have low back pain because they haven't corrected any of the problems that cause the low back pain. SI joint is common due to ligamentous laxity. And a lot of times that sticks afterwards. Now they make these things called SI belts, which are belts that you can put on that kind of tighten up that SI in the back and kind of lock it down. They feel really good. And sometimes that alone can relieve mom's back pain. But we know putting a brace on like that weakens the strengthening muscles around it. So it's not fixing it. It's just kind of bandaging the problem. So, you know, if you get somebody that's got an SI belt, okay, it can be helpful, but they don't want to be wearing it constantly. External stabilization may help, which is what I was talking about, including Therex. Some women suffer from pubis symphysis pain or subluxation, right? I actually saw once there, so if we've got our pubis symphysis coming down here, right? I actually saw a mom that after birth, the pubis symphysis looked like that. Instead of coming together right here at that joint, they actually, one slipped down underneath the other. Yeah, right. And I don't care if you're a guy or a gal, looking at that going, oh, because baby had literally ripped mom. She had a stage 4 episiotomy and it tore a lot of the stuff. That would be a dislocation, yeah. So subluxation would just be, so how do they fix it? What do you think they're going to have to do to fix it? Surgery. Yeah, they're literally going to re-dislocate it, place it back together. And I think they do like a transplant ligament, or I don't know fully how they do it, but they've got to get them pulled apart while mom is unconscious and then kind of fit back together. It's kind of like the Lego pieces aren't fitting, right? They've got to put the Lego pieces back together. Now, is that area always going to be forever weak then? What do you think? Even if it doesn't fully do that, it just subluxes. Yeah, it's probably going to be forever weak. Meaning mom's going to complain about doing stuff like the mom that I had that had this, I didn't have it. She was in the clinic that I was in. I saw her and I got to see the x-ray. It was it was neat from a medical perspective to see it, but definitely not neat from her. She noticed that she had baby and then went back to her spin classes. And her main complaint was every time she was doing a spin class, she felt like something was grinding in her pelvis. And so they went in and did an x-ray and found out that the subluxation, actually dislocation, had happened. And so think about it, when she's sitting on that bike, literally that pelvis is doing one of these numbers. And it was literally grinding. Very close veins or varicose veins are common, right? Often aggravated during pregnancy. Elastic sports stockings can aid with external pressure. So, and some of the moms miss out on it. They don't use these external support stockings and they end up with swelling the legs and varicose veins. But why do you think the number one reason if a mom that is pregnant is prescribed stockings, they don't put them on? Let's think logically about that for a second. Yeah, I can't reach. Exactly. Like I saw a patient once that they gave her stockings like that. And like mom had big baby belly. And she's like, the doctor gave me these Job stockings to put on. How the hell am I supposed to put these things on? I haven't seen my toes in weeks. And so we had OTA get her a sock aid, help pull those stockings up. And she was like forever grateful. She's like, this is so much easier. Now getting them off was another problem. She had to have help getting them off. So there's all kinds of problems. Pelvic floor dysfunction happens. And it's mainly because support for the pelvic organs and that becomes laxated, right? Innervations include the pudendal nerve and the direct branches of S2, S4. So we know that S2, S4 is going to innervate that whole pelvic area. So that means we talked about it with the spinal cord injuries. That would be the area that could get damaged also with baby. Joint laxity is also known to cause due to hormonal problems. And they can end up with problems with weight bearing, right? Swimming, bike riding, any type of activity is good for this. Most pregnant women will tell you that any type of a water activity, a water therapy program is probably best for them. They prefer that because, again, it de-weights them a little bit. And just as a funny kind of aside here, because I made this joke before and I got yelled at, but it's still kind of funny to me. If you think about it, when mom gets in a pool, she becomes a submarine. No? No one liked that joke. Darn it. Such a hard crowd. It's a dad joke. Yes, it is. Probably a dad Jake too, but I'm just saying. So what other stuff can happen? Compression syndrome, TOS. TOS is huge in patients, pregnant patients, because they get that kind of forward rolled shoulders. Carpal tunnel syndrome and ulnar tunnel syndrome can occur, right? So this is where if we have a patient coming in with this, we have to play chicken or egg. Because what if they're complaining about carpal tunnel syndrome? Could that be caused by thoracic outlet syndrome? Yeah, it absolutely could. If I've got my thoracic outlet up here compressed, that can press down on all the nerves coming down, right? The brachial plexus and everything coming down my arm. And therefore I get carpal tunnel syndrome. That may be my only symptom. Or it could just be carpal tunnel syndrome. Maybe my wrist is swelling because of baby weight, or I'm getting a little bit of peripheral edema. And so now I'm getting carpal tunnel syndrome. So we have to kind of play along going, okay. And this is hard for PTs, right? Because they've got to diagnose this at the eval and go, okay, this is 100% carpal tunnel syndrome, or yeah, this is carpal tunnel syndrome sequelae to thoracic outlet syndrome. So carpal tunnel syndrome, right? We're going to have pain here in the palm, these first three fingers, right? And what's going to happen to the thenar eminence during carpal tunnel syndrome? The thumb hump. It may swell at first, it may go numb, and then it's going to atrophy. And it's really common to see, and I don't know, let me see if I can get my hands up. I don't know if you can see, there we go, the difference in my left thenar eminence versus my right, but you probably can't because we're too far away. My left is pretty well wasted away. I mean, I can feel all the bones there in my thumb really easy, whereas on my right side, because I don't have nerve injuries on my right side, I can actually find all the little bones, and it's a little harder to find the bones. There's much more cushion on that right side, which means now if I was in the martial arts doing breaks, I'd probably want to break with my right hand, by a little more support. So that's carpal tunnel syndrome. Where's ulnar tunnel syndrome going to look like? What's that going to look like on the hand? Same but other side. Good, right? So it's going to be pinky side and maybe a chunk of the ring finger, right? And then what's the other eminence over here called? If this is the thenar eminence, you remember what this one's called? The hypothenar. Yeah, and they're going to hypothenar wasting. So we know that carpal tunnel syndrome is which nerve? This is a review session partially as well, because I'm going to use this to get you prepped for the boards. Good medium, good. Which is what sensory innervation? Primarily. What roots? 6, 5, 6, and then maybe a little bit of 7 with the middle finger, right? A little branch of it, because we know that C7 is the one that goes it alone. Okay, good. So that means ulnar is going to be what? C7, C8. Yeah, right? Good. And maybe even there's some people that you can get a little T1 up there too, but again, we're all a little different in it anatomical wise, right? Sometimes some people may just be pure C6, okay, for that median nerve. All right, so if we know that median nerve gets compressed here at the carpal tunnel, right, by that, what's this retinaculum called here? The retinaculum is that piece of ligaments that goes across. Palmar, close. Good guess. What are the muscles? There we go. Flexor retinaculum. Yeah, see? That means on the back, what retinaculum do we have on the back? The extensor retinaculum. Good. See, you didn't think I was going to make you do board questions while we're learning lessons. Too bad. I know. That's why I'm clearing it off, right? So we know that that's where typically the median nerve gets compressed, is in that carpal tunnel, right? So we're going to do a lot of opening that up. But we've got to be careful again, right? Because we know that pregnant women have relaxin. And if we open that up too much, we could really kind of stretch that stuff out a little bit. So we want to be careful, right? Very careful. Where would the ulnar nerve get impinged at? What's the structure in the wrist it gets impinged at? It has a very specific name. Now I said at the wrist. We'll get to the elbow in a second. Okay, good thought. It's over at the styloid. Good. If this is the carpal tunnel, what's the tunnel over here? It's Guillon's tunnel, or the canal of Guillon. You remember that from anatomy? Oof. No? So I'll spell it in the chat just so that. It's one of those 3 terms. Doesn't really matter which one's used. They're all kind of synonymous, right? So over here, yeah, I think Dr. Reskin talked about it. I know she has, because she has that in her hand lecture. Trust me, that's one I know she has in her hand lecture. It does sound a little bit like Guillain-Barré, right? But that's, again, I'm sure probably eventually we're going to call this something like the ulnar tunnel, and it may be getting called that nowadays. It's not in hand therapy yet, but we're eventually, because Guillon's canal is kind of a name, right? We know that we're getting rid of most of the names in the human body. So that's where it gets pinched here, right? Out here on that lateral aspect. Where does it get pinched back here in the elbow, like Sukina said? What tunnel back there? We're talking ulnar nerve. Cubital tunnel, good, right? And what's the other, what do we call the cubital tunnel? Colloquially, how do you spell that word? That's our, ow, we banged it. It's our funny bone, even though it's not a bone, right? Because when we bang stuff, we're not really banging the bone, we're banging the ulnar nerve, right? So the funny bone is really, yep. Okay. Yeah, the median nerve kind of dives, right? It keeps itself safe, which actually, it does sound kind of dumb that it's out there, but it makes sense that the median nerve is protected. Because when you think about it, if I lose my ulnar nerve and I get claw hand deformity going on, can I still do stuff with my hand? Yeah, right? Whereas if I lose this and this all gets deformed, my pinky and my ring finger aren't very useful, right? I can't move them independently. These fingers I can move independently of each other, right? But try just putting your hand straight up and try just moving your ring finger without moving anything else. It doesn't typically work, right? You don't necessarily have that motor control. And definitely like my pinky, I can't move my pinky by itself at all. It doesn't work that way. And I always find it funny when we were trying to get our hands placed for martial arts that he's like, no, just your distal joint flexed. Yeah, that doesn't happen. So that's where that all, but all of that is going to go back up to my brachial plexus. And so if I've got that forward rolled shoulder at the thoracic outlet, could cause problems. Could I have a blood issue from thoracic outlet that could cause me neuropathy? So instead of the nerves being pinched, now the blood vessels going to the arms being pinched. Yeah. Right? Good. What is one name of one test for thoracic outlet syndrome? There's a couple of them. One starts with an A. It's the most common. Adsons. Yeah, there you go. See, you guys did not think you were going to get board questions while you're sitting here learning about the pelvis. It's not because the pelvis makes me completely uncomfortable at all. No, not at all. But yeah, so now I get those problems on my arm, right? So that can be it. I can also get issues with all the nerves in my neck. Do you think pregnant moms could suffer torticollis? Well, let's think about it. Mom's got to lie on one side pretty much only, right? Because if she lays on the other side, she could die, literally, not even joking, with our aortic occlusion. If she lies on her back, she's really uncomfortable. So pretty much the only side she can lie on is that left side. And now I'm laying on the left side and I've got a pillow over here, right? And we all know our pillows are not designed exactly for ergonomics, right? It's okay. It's actually a really common problem in, in office jobs, because most people don't have their computers set up. Like I've got a whole bevy of monitors around me. I love this because I can just turn and turn and turn and turn, and I've got monitors everywhere, right? But if I'm a person that's like this and I'm talking to you, I can get torticollis just the same, right? But let's just think about our pillows. How many of you guys actually have a pillow that you like? Like I still have yet to, in my adult life, find a pillow that I like. Okay, I have a pillow, right? I have a pillow, it's there, but I definitely don't like it. Okay, so good, you like your neck pillow. I just haven't found one. I want to try one of those. Have you seen the new Cube pillows yet? I actually want to try one of those. I'm curious because I get a lot of neck pain in my sleep because of my neck, but I guess I'm just a giant pain in the neck. But think about it. So mom's laying on a pillow. Now her head's kind of either cocked this way or the pillow's too low and she's cocked this way. You can get torticollis. That could lead to thoracic outlet. So we got to work on postural correction exercises, right? Ergonomic assessment. Heat in the upper body is okay, right? Because heat up there is away from baby. Ice, splinting as necessary. Very rarely will mom get carpal tunnel surgery while she's pregnant, because docs are going to try to avoid any type of surgery. Not good for baby to have mom go under with anesthesia. Babies do not react well to anesthesia. Again, if I'm in the clinic and I see a patient with carpal tunnel, I really like carpal tunnel traction. And did any of you see that while you're in clinics? Does any of you have, there's very few clinics that have the actual carpal tunnel traction unit. They actually have a whole unit that attaches to like the regular neck traction and spine traction unit that's designed for carpal tunnel. And it's really cool. Like I've been at 2 clinics that have it, and it's amazing what you get out of pulling those bones just a little bit apart and giving that carpal tunnel room to breathe. Even if it's for 10 to 15 minutes, it's funny, you put the patient on it, they don't believe it because they can't relax because it's pulling on their arm. And about 5 minutes later, they forget what they're doing to their hand. And all of a sudden they're like, oh my God, I can move my fingers again. because they've relaxed and the carpal tunnel is now opened up. It actually does. I'll find a picture of it when we go on break, just so you can see what it kind of looks like. Pelvic floor. What kind of stuff do they have? They can have prolapses, right? Viscera can be pushed out of normal alignment. It is very common for moms to get urinary and fecal incontinence, right? And this is where I really feel for mom, because at this point, baby's doing some stuff that's just not nice, right? It's nothing for moms to have, we'll talk about urge incontinence and other kinds of incontinence, nothing for mom to have that. They may be pain and hypertonic in the pelvis as well, meaning that it's harder for them to fully empty the bladder or fully empty the viscera as well. So we're going to work on pelvic floor muscles. We're going to work on core. We're going to work on neuromuscular re-ed with these patients with posture. Superficial and heat and ice is okay as long as it's away from, or superficial heat specifically, away from baby. But we want to avoid deep heat, even with, and this is one of those that I kind of avoid, even if I'm working on the patient's carpal tunnel. I don't like to do ultrasound. I don't like to do laser. I just kind of shy away from it if mom's pregnant and say, we'll get there when we get pregnancy out of the way, right? So when we get baby gone, we can maybe get back to those type of modalities. But again, that would be up to the PT, not up to us. If the PT tells us to do it and instructs us on how to do it properly, then we do what the PT tells us. I have questions sometimes, and it's okay to ask a question. It's not okay to question the PT's judgment. But I have asked some PTs that, they order low back heat, and I'm like, hey, do we really want, why are we doing the low back heat, just so I can understand it? And usually the PT's response is, oh, I didn't even think about that. Thanks. Right? Because, we don't want to do low back heat on mom. TENS and E-stim postpartum can really be helpful. We'll talk about different biofeedback devices when we get to the pelvic floor area. But it can be really useful for that gait control theory to help with pain, especially. When we're working with the pregnant mom, I guarantee one of you guys are going to get a question on your boards that asks about working with balance with mom, and one of the answers is going to be single leg stance. If there's ever an answer about mom, that if mom is pregnant and there's an answer about single leg stance, it is probably the wrong answer. That's just mean. Think about that for a second. Is it really nice to put mom in single leg stance? That's a lot of weight going down through one leg. And it also, now we've got babies, got to shift. No, don't do that. That's just mean. Keep supine to a maximum of 5 minutes after the 4th month due to vena cava compression. I'm really particular about this when I've worked with pregnant women. I don't let them on their back more than 3 minutes. It's just a precaution, and I literally set a timer. So if I'm doing something like, maybe I'm doing, I've done, what's it called? Yeah, myofascial release on the feet, in order for plantar fasciitis. I will only allow her on her back for maximum of 3 minutes. I can do most of it when they're seated anyway. Have a patient empty the bladder. I said that as well. Monitor for signs of bleeding or pain. Any new pain in the pelvic region or bleeding is an immediate do not pass go, do not collect $200, stop therapy. Here are some absolute contraindications to exercise. I don't know why this term just confuses me, but incompetent cervix just sounds weird. Doesn't it? Like, you got an incompetent cervix. I don't know why. It just means that the mom is prevalent to early dilation. That means baby may crown early. We don't want that, right? So if mom has incompetent cervix and the doctor will indicate this, they're probably not good for therapy. Vaginal bleeding of any amount. If mom says, oh yeah, I went to the bathroom, I was bleeding a little bit, but it's nothing major. It's always major. It is awful terminology, right, Erica? I don't like that term. But any form of vaginal bleeding at all is a non sequitur. We've got to stop, because even a little bit of bleeding can be baby bleeding, and we can't risk that. Placenta previa. This is where the placenta lies low enough in the uterus and it partially covers the cervix. Is that going to cause problems with birth? What do you think? Yeah. Right. And this is a pretty serious medical condition. If we have a serious medical condition in almost any of them, we're probably not going to do therapy. Any loss of amniotic fluid. I can't believe I have to say this. If mom's water breaks, Stop therapy. I actually had a student once that said, how do I know if mom's water breaks? Oh, you'll know it. Oh, you'll know it. Yeah, right. That was not something you missed, moms that are in here, right? You didn't suddenly, wait, did I actually drop this baby gone? Yeah, water really breaks, or rarely breaks. Yeah. It's no, really, when it does break, it really breaks. It's also the truth. I've dealt with a couple moms that have gone through when they're getting ready for birth and that water breaks. It's you'll know it. Yeah, but if it breaks during therapy, it was kind of funny. Like, well, how will I know? Just let you know, you'll know. Yeah, it does seem like more in movies, right? You're right, but still, if it happens in therapy, you'll know. Premature labor before the 37th week. Is it normal for a mom to have some contractions going throughout the whole pregnancy? Or like feel like she's having contractions? Yeah, it's normal, right? But if she's having contractions where she feels like she's going into labor, abnormal. If mom goes into labor, it's time to stop doing straight leg raises. Right? Just stop. I know this seems kind of funny, but I have to say this. If the mom has heart disease, they'll know the difference too, yeah. If the mom has heart disease, we're not going to do therapy. And that kind of makes sense, right? Because if we're working them really hard and the heart is already having problems and they have baby, no good. Maternal diabetes or hypertension, in intrauterine growth retardation, where we've got problems with either growth of the uterus itself, maybe the uterus didn't grow itself, or there's a problem with baby growing inside the uterus. Probably not going to do therapy. I know I have to cover these, but if you get a question on your boards about safety, I put this up here because this is most of the questions you're going to get about safety with an obstetric patient. The only other one is single leg stance, right? So if mom can't do supine for too long, she can't do right side lying for too long, can she do quadruped? Yeah, that's actually an exercise position where we do a lot of our exercises in, right? Because that kind of takes the weight off the low back a little bit and actually gives the aorta a little bit of breathing room too. So we might do a good bit of exercise, but understand putting mom in quadruped may not be the most comfortable for her because now baby's pulling down on her belly, right? So you have to think about that too. Most of your questions with pregnant women are going to come down to safety. They do natural births too, yep. Right, and water births and all those other funky births. I've only participated in one birth ever, and that was of my goddaughter. And if I never see another birth again, it's going to be too soon. It was like a horror show to me. And I was only 18 at that time. So I don't know why I agreed to be the alternate. I should not have agreed to be the alternate. All right, so some precautions to therapy. So we talked about contraindications. No, it was purely horrifying to an 18-year-old me. There was no magic about it. I'm sorry, it wasn't. There was no magic to an 18-year-old me. That was the most terrifying experience I could ever. Yeah, no. And the best part is my best friend showed up at the very end. Like, you jerk. Anyway, precautions to exercise. Multiple births, twins, triplets, quintuplets, sextuplets, octuplets, right? Any of those are going to be precautions. The more babies, the more risk. Anemia. If mom is anemic, that means that she doesn't have enough oxygen transport capacity, which means she can be really weak during therapy. Systemic infection. She gets a systemic infection, we got to watch it. Extreme fatigue, extreme complaints of musculoskeletal pain or just achiness. Overheating, phlebitis, I can speak today. Inflammation of the blood vessels themselves. If they have diastasis recti, we're going to mainly worry about doing ab exercises and following safety there. And then if doing exercises causes any form of uterine contractions, we definitely want to notify PT. We definitely want to notify her doc. because that way they have some documentation on it. Let's take a break here. I'm gonna stop sharing. That's kind of it for mom. So I'm gonna pause it here. All right, so we're gonna resume recording here. So we had just before break started up or finished talking about pregnant patients. Is there any questions, or do any of the moms in here have any other types of stuff they could, is there anything that you guys experienced that you might think is beneficial for your fellow students that maybe they don't understand, especially honestly, us guys who can't ever go through this? One thing I'll also say to dealing with an obstetric or a pregnant patient is just listen to them. A lot of times it's just like our other patients. Pregnant women don't feel like they're being listened to as much because, well, you know, hormones are out of balance. That causes problems. And maybe they just aren't being listened to as much. And so just even listening to them, you know, have a little bit of a breakdown on you because they feel like their body is completely out of their control can have huge impacts on them. So, you know, spend some time just listening to what their concerns are, listening to, you know, how they feel and stuff like that, just so that it makes them feel a little bit better. And then also you guys might learn something. Do we have any questions about pregnant patients? Are we ever, that's a good, I should thought of this. Are we ever going to do any therapy on baby while baby's in utero? No, that just seems silly. I would be pretty confident that if you looked out there, there's probably some form of therapy that claims to do intrauterine therapy with babies. I'm sure somewhere. If not, then wow, that's a missed snake oil market. I'm just saying. But yeah, so it can be interesting. It can be, honestly, working with pregnant women can be really rewarding, can be really frustrating too, because you honestly start understanding how they're suffering and stuff like that. And it really does prove that babies are little parasites. I'm just saying. All right, so we're going to move on to incontinent patients. Now, the majority of what we are going to talk about is urinary incontinence, but we will talk some about fecal incontinence as well. So urinary incontinence is the leakage of urine at inappropriate times. When is it inappropriate to leak urine? During sleep? I would hasten to say, sneezing, I would hasten to say anytime that you're not directly in front of a toilet is probably an inappropriate time to leak urine. Would that be a fair assessment? Pretty much, right? Yeah. So in incontinence, the patient may have trouble starting the urine stream, holding the urine stream. They may have a problem holding the urine itself. They may have a problem with emptying the bladder fully. There's all kinds of different problems that can occur from this. Usually involves the muscles of the pelvic floor. It also touches the bottom of the pelvic bones around at the back, forming that bowl-like structure, which I already talked about. They also help support the low back, stabilizing the pelvic bones, and help with sexual function. It is more common for women to report, and I says it's more common for women to have urinary incontinence, but I would be more likely to say that it is more common for women to report urinary incontinence. Why do you think men don't report urinary incontinence? Too embarrassed, which is silly, right? I mean, look how long we've had, look how long we've had adult brief commercials, and we've had feminine products for dealing with urinary incontinence, and just now we're starting to see men's products for urinary incontinence, right? There is a certain stigma that goes along with it. Also, I sometimes wonder if men even know that it's happening. Now, if it's severe incontinence, yeah, but I just sometimes wonder if women are more cognizant of it than men are. So there's also that as well. Of course, fecal incontinence is the leakage or release of any fecal matter at inappropriate times. And again, I'm going to say here, anytime that you're not above, around, near a toilet is probably an inappropriate time to leak fecal matter, right? That's just kind of what it is. Literally, you're exactly right. So it may involve muscles of the pelvic floor, abdomen, or maybe an incompetent external canal, anal sphincter, and we'll talk a little bit about that type of stuff. So there are two main types, and then we'll talk about mixed and functional. The two main types that we have are stress, and this is amounts of urine leak or fecal matter leak when there's increased pressure. And then urge, and this is where the bladder goes into spasm, and spasm is severe enough, medium to large amounts of urine will leak. This might happen occasionally or as often as every 15 to 20 minutes. So you can have stress and you can have urge. The other one you can have is mixed incontinence, and that's a combination of them both. And then there's also this term that's called functional incontinence, and this is pretty common in the patients that have Parkinson's. This isn't that they can't hold their bladder or they can't empty their bladder at the appropriate time. It's just that they're not fast enough to get to the bathroom in time in order to empty their bladder appropriately, especially patients with bradykinesia and stuff like that. So stress incontinence is probably one of the more common reports from females, just because they literally get a little stressed out about it. Right? Stress incontinence happens when weakness and lack of support of the pelvic floor muscles happen. It can often happen with laughing, sneezing, coughing, or with exercise activities such as lifting. Women with stress incontinence often have an underactive pelvic floor muscle, meaning that pelvic floor, yep, exactly. We're actually going to talk a little bit about the exercise type people that have it as well, right? The pelvic floor becomes overly stretched. Right, and this does not as strong, right? We work on, and this is common in the human body to me, right? Let's think about the shoulder. When we go to the gym, right, we do curls, we do tricep extensions, right? We do lat pull downs, right? We'll do flies and reverse flies, and we'll do all these exercises, but we never do, or rarely do you see people in the gym working internal external rotation, right? And if you see somebody working internal external rotation, they've probably been to a PT clinic where they have an injury in the shoulder. That's a common thing, right? I mean, because of that, exactly, Dylan, right? Before I injured my shoulder, I never, when I went to the gym, I never did internal external rotation. I didn't even know what it was. Then I injured my shoulder, right? And now I learned, oh, right? And then I saw Over the Top and realized that I can become a world-class arm wrestler, and no, just kidding. But it's the same thing in the pelvis, right? We work out the rest of our body. How many of you guys, when you go to the gym, do pelvic floor exercises? If any of you say yes, I'd be really surprised. Yeah, I go to the gym all the time and work out my pelvic floor. Not on purpose, right? Yeah, and we're going to talk about this, right? So what can cause weakness of pelvic floor? Pregnancy, which we already talked about, other injury or trauma, and this includes sexual assault. Sexual assault can cause bad pelvic incontinence, right? Surgery in the vagina or rectum, episiotomy from pregnancy, or other reasons. Episiotomy is not only due to pregnancy, it can happen for other reasons. Lack of exercise and lack of use, and like Renee said, certain types of physical activity lead to more tendency towards pelvic floor issues. Gymnastics and dance are two of the ones that I've mainly encountered before. Mainly because with gymnastics and with gymnasts and with dancers, one of the things they work on is really, really making their body flexible. And if you stretch your legs out so they're very flexible, inadvertently, you're going to stretch out your pelvic floor, right? And it's not going to be as tight as it was. It's really, really common for gymnasts to have pelvic incontinence, and somebody like that does performing arts. After delivery, women can also have fecal incontinence if there's tearing of the vaginal opening, extends the anal sphincter as well. Urge is a little different. Urge incontinence is spasm-related incontinence, right? The patient may have pelvic floor issues, right? They may not have the strength in the pelvic floor to hold back that urge. Meaning that, you get that sudden urge, and we've all had that, right? We've all been sitting or maybe driving down the road, or you've been in class with me, and suddenly your brain goes, hey, I gotta pee. And you make that mental decision. Okay, do I have to go right now? Can I hold it? No, I'm okay. I can hold it. And then the longer you hold it, the longer that urge gets, or the harder that urge gets, right? And eventually you get the what I call the child having to pee kind of thing. You have to go pee? No. Are you sure you don't have to go pee? No. Right? Getting that little bit of wildness going on. You know, they have to go to the bathroom. They're just not admitting to it. But with that, patients that have urgent incontinence may not have the strength of that pelvic floor to hold that back. Interestingly enough, research is starting to show that the problem with urgent incontinence is more central sensitization. Do you remember I talked about peripheral sensitization versus central sensitization back in the chronic pain lecture that caused you guys chronic pain? Right? So central sensitization, meaning it's a problem with the signal coming from the central nervous system. And we're starting to see more and more of this where urgent incontinence is leading back to it being more centrally nerve mediated and the signal's getting crossed. Now, if we know that, so let's say we know that urgent incontinence happens, we know that they might have a weak pelvic floor, we work on the pelvic floor to help with urgent incontinence. If it's a central sensitization issue, we're going to have to habituate them for it, right? Get them knowing that as soon as they feel that little bit of urge to go to the bathroom, they got to get to the bathroom because they may not have time much after that. But in reality, when you think about this, and like parents, I kind of want you to chime in. What you're doing when you potty train a kid is nothing more than habituation of a central sensitization issue. Right? Because you're teaching a kid that to go to the bathroom on a regular schedule, first of all, preferably, right? And if not to go on a regular schedule, to know that once they feel that urge they need to go to the bathroom. That's central sensitization training. You guys just didn't know you're doing something fancy. See, moms and dads, you're a lot smarter than you thought you were. Right, gotta pee, gotta go potty, let's go potty, right? Exactly. What you're teaching them, part of it is it's okay to go potty, right? Because sometimes, you know, there's a little stigma there, right? And I don't think that sometimes us putting them on potties in the middle of the living room helps that. I'm just saying. Well, I mean, logically, let's think about that, right? How would you feel if your toilet was in the middle of your living room and when your guests came over, you just went over and sat on the toilet? Let them run around naked. Well, I mean, that teaches them other things, but teaches them not to be ashamed of their body as well. But that's beside the point. But think about that for a second, though. Right, we are, even animals leave the pack to go to the restroom usually. So there's something about that that's primal there. I'm not sure what. So that's kind of urge, right? And if we know that it may be centrally related, we may have to habituate it. So we may have to strengthen the floor, but we also may have to teach them maybe getting on a bladder schedule where, okay, so every 2 hours on the hour, go to the restroom. And that kind of trains them to make sure they take care of their urgent incontinence. Functional incontinence typically isn't related to the bladder or pelvic floor muscles, right? This is weakness that causes the patient to move with difficulty. If I had a total knee replacement, could I have functional incontinence? Yeah. I had a patient once that he was a Air Force captain. No, not Air Force. He was a Marine captain. I'm sorry. Marine captain. And he had spinal surgery in his upper neck. He had 5 or 6 levels of his neck fused. But he had really, really bad post-surgical pain. And the one thing that embarrassed him the most was he knew when he had to go to the bathroom, he knew to get on a bladder schedule. But unfortunately, because of that pain in his neck, it took him so much to get out of bed. I'd come in and he would be just absolutely mortified that he wet the bed or, had fecal incontinence because he wasn't able to get out of bed to go to the bathroom. Right. And that can be really hard on somebody if they're used to being fairly self-sufficient and not having to worry about other people. And that's, again, part of the reason I think that when we look at older gentlemen, that older gentlemen may not even, whatever type of incontinence, whether it's functional, urge, or whether it's, a sensory type or a pelvic floor incontinence or a mix of all of it, that they don't report them because there is that embarrassment factor. Also, if you have a patient that's confused demented or delirium. Yeah, right. I was reading there's this thing talking about how it's not I remember reading, I'm trying to think of what magazine I was reading this in, but there's an article on the incontinence issues of the 1960s and 70s on LSD, because people were taking LSD and tripping and not realizing they had to go to the bathroom because, well, they were seeing purple dragons flying around the room. Kind of interesting thought process. Environmental barriers. What if the bathroom's too far away? What if the walker slows them down? What if there's stairs? That can cause functional incontinence. Psychological problems is depression or anger. And when you think about this, right? Let's say you have one episode of functional incontinence. It frustrates you, it makes you angry, but you start getting into that cycle of, I can't do anything about it. And the next time you have functional incontinence, you get briefs or adult, depends, stuff like that. And you start wearing those. And then you were like, well, I don't have to change them yet. This is only the third time I've peed in this brief, right? And they just get this depression that goes along with it. The patient can also have an overactive bladder where the bladder empties frequently throughout the day and makes the patient get up more than urinate at night, right? There's all kinds of things that can cause this. So, whoops, that's not what I want to do. There we go. I was trying to scroll somewhere else and that happened. So yeah, so there's all kinds of reasons that can cause dysfunctional incontinence. So back here with stress incontinence, right? We have to fix the problem with the pelvic floor or whatever's causing the problem with the pelvic floor. With urge incontinence, we may have to centrally sensitize the patient and provide them with a urinary schedule. With functional incontinence, it doesn't matter what we fix if we don't fix what's causing the functional problem. If we don't help them with getting up and getting out of the chair, if we don't help them with maybe reducing the distance to a restroom for them, stuff like that, they're going to constantly have it. So all of these have different, not diagnosis is not the term I want to say, they have different solutions to them. And if we don't figure out what's the first part of it, we can't provide them with the solution themselves. So how can we help? Well, based on the evaluation, an individual treatment plan can be developed, right? And the main goal of pelvic health is to gain control over your symptoms, reduce the need for pads and special undergarments, incontinent medications, and possible surgery, right? I don't care how pretty and awesome and sexy they make incontinent style briefs, they're still not comfortable. Not that I would know that, I'm talking from a patient perspective. They don't feel good, right? Would it make you feel good if you knew that you guys had to wear a brief all day long as an adult? Just, I don't think it would make me feel good, right? I mean, I realize that like professional gamers do it all the time, but I'm not that hardcore. At least I made Jaira laugh. Good. And Jaira knows exactly what I'm talking about, those Dota tournaments. That's why I call them briefs and diapers, right? Yeah, because they should be worn briefly. You're right, Emily. It's actually a really good point, right? And the other thing is man, if you don't ever say to an adult they're wearing diapers, you might get hit. So the key to finding the right muscles and using them correctly, right? Using pelvic floor exercises, PT can help strengthen those muscles and help control the bladder. The key with these patients is to show them how to find the right muscles and use them correctly. That can be the most difficult part. Use pelvic floor exercises to strengthen the muscles that help control when bladder occurs. The pelvic floor exercises include the gold standards called Kegels, which we'll talk about, in which you gently squeeze the sphincter muscles and squeeze the buttocks, thighs, and stomach. Instruct the patient to stretch and strengthen other important muscles so those muscles can help support bladder function. We also want to make sure we strengthen our abs, right? Strengthen our transversus abdominis, strengthen the hip muscles so that they can help support those pelvic muscles. And then depending on the symptoms and level of discomfort, we can use biofeedback. We're going to talk about that in a bit just to see how we can actually use biofeedback for this. But electrodes can actually be attached vaginally, rectally, and penally in order to provide measurements of muscle activity. This doesn't sound like fun, but here's the deal. And I teach this class, and it was funny because I actually volunteered for 2 weeks to cover for a pelvic floor therapist way back when. I didn't quite know what I was getting into. Yeah, we're going to talk about that, AJ. Didn't quite know what I was getting into. they said, hey, McKeever, you cover everything else. Would you mind covering pelvic floor for 2 weeks while the pelvic floor therapist takes off for vacation? I'm like, sure. Well, and they're like, of course, you got to go learn what the therapist does. They're like, so I need you to go shadow them for a week. That was an eye-opening experience. I didn't quite know what I was getting into. And what I found about that 2 weeks is no matter how embarrassing the patient may find it, no matter if you think that a male can't be a pelvic floor therapist or a female can't help a male pelvic floor therapist, for the most part, the only thing those people care about is, how do I get better? They're very much like a chronic pain patient. How do I make this go away? Right? They don't care who you are, what gender you are, what you're doing for the most part. How do I make this go away? Because it's impairing their life, right? And yes, we can use electrodes. We'll talk about different types of stuff we have different tools we can use. So here is external palpation of the pelvic floor contraction. This is the primary method you will use for palpating pelvic floor contractions, right? Now, everyone's looking at this going, hoo boy. How many of you in here are saying, oh, no, not me, I'm done. I'm looking at this right now. I'm out. He's like, I'm out. Okay. It's good to admit that. Yeah, well, there's theories on that as well. I'm not going to get into theories. I agree, Kelly. She should have gloves on. But there's in the pelvic floor community, there's this theory that human touch is still important, blah, blah, blah. Yeah, you could, right? And think about it, because you're going to have exposed areas of the pudendal nerve and S2 to S4 that could trigger points on the pelvic floor. Yeah, absolutely. Yep, you can absolutely. Now, I haven't seen, and most of the time that I have pelvic floor issues like that, Sukana, it's going to be that obturator muscle that are going to be trigger point related, because the pelvic floor itself is mainly ligaments. So you can't really get a trigger point in a ligament, but it's going to be mainly the muscles that support it. You can get it in like the external anal sphincter. You can get it in some of the levator ani muscles and stuff like that, or even in something like the piriformis that can cause problems. Now, what you don't realize there is she's not literally up into that person's business, right? She's actually on the side, very, very close to up in her business, just on the side of the butt cheek. And trust me, just that location there alone, you can feel if the patient's doing proper Kegels, right? If there's external palpation, guess what? There is also internal palpation. Now AJ is really out, because there are two different forms of internal palpation. It is gone, right? There are two different forms of external palpation for pelvic floor, right? And there's not a anterior pelvic floor palpation for men, is what I'm saying, if that makes sense. There's only a posterior pelvic floor palpation for men. Yeah, Kelly's like, oof. Okay, now is this combined with yesterday is kind of crushing all the guys here right now. But, and this is the thing that I'm going to get at, is because this was the part I freaked out about. Second patient, we go in and the therapist is like, I'm going to show you how to work on internal Kegels with the patient. Mr. McKeever's eyes probably about as wide as AJ's are right now. And yes, and we're going to talk, that's exactly what we're going to talk about. Yeah. My eyes went about 16 millimeters of dilation. And I'm like, okay, this is a nope sandwich with the side of nope sauce and nope fries. Because I figured that the patients coming in are going to see me as a guy and be like, absolutely not, you're not doing this, right? Internal palpation probably should be. Yeah. And again, that's going to be one that's going to be PT related, right? Let the PT decide that. I'm not going to decide that. And actually what it ended up happening is the patients that had internal palpation with me, we worked on external palpation for 2 weeks, which they were fine with, the PT was fine with, and I was actually pretty much fine with, because I just saw this as a big red flag for lawsuits to me, is what I saw. But when you talk to the ladies, and actually we had 2 guys that were there as well, they were fine with whatever because they didn't care. It's much like a spinal cord injury patient. At the point that you're coming in for this type stuff, they don't care. Right. And AJ said the Dr. Nasser, where was Nasser from? Do you remember, AJ? What school was that from? Yeah, Michigan State, right? And also the guy from Ohio State tried to claim the same thing. The coach from Ohio State claimed that he was trying to help some of his students with urinary incontinence. Sure you were. And there was also a doctor that I remember that, yeah. There was also a doctor, I don't know if you guys saw this, but there was also a doctor that worked with Andrew Yang's wife that did a similar malpractice. Andrew Yang, the guy that ran for president last year. And there was a whole write-up on that doctor. So that being said, could this lead to creep people? Absolutely. Could, right? But I would hope that most people going in for this profession are going into it for the right reason, right? It's just like, and I don't want to judge anyone going into this profession for pelvic floor health because it's needed. And me going into pediatrics was looked at the same way. For some reason, there's still a stigma of guys working with kids, that they're weird. And for the most part, some of the therapists that have been in pediatrics for so long are happy to have some guys come into pediatric therapy because they'll give us all the heavy kids. Like, yeah, go work with him. He's a tank. But yeah, again, most of this, if you're working in pelvic floor, and I'm joking a little bit, but I'm not joking about the actual content. Most of the people that are having this problem don't care. They don't care if you're male. They don't care if you're female. They don't care if you're non-binary. You know, if you identify as a tree, whatever it may be, they just want to get better. And I guess if you identify as a tree, you can branch out into pelvic health. So let's talk about Kegels. Oh, come on. That was kind of funny, guys. I slid right into that, didn't I, Matthew? All right, so let's talk about Kegels. What should we have a patient do with Kegels? Ideally, even you guys, this could be beneficial to some of you guys as well, and gals. When I say guys, it's non-gender specific. Please understand that. Have the patient try to perform a minimum of 45 contractions per day. Each of those contractions, they're going to hold with a 10-second hold with a 10-second relax between them. Usually we break them up as following: 15 standing, 15 seated, 15 supine. Well, why do we break those up that way? Well, those are all three of the positions we're going to be in throughout the day, right? It kind of makes sense that we want to break it up and change up their process. So then I get this question a lot. Well, Mr. McKeever, I can't hold my Kegel for 15 seconds. I can only hold it for 5 seconds. Okay, great. Do 5 seconds. Right? We'll build up. It's just like, you know, for those of us that go to the gym, we didn't start bench pressing 225, except maybe Justin. Justin may have started there. The rest of us had to work to get there. Right? No shot. But it's just like any other activity. If we want to get better at it, the only way we're going to get better at it is practice. So caution when we're doing Kegels. We're only going to contract the pelvic floor muscles. You don't want to strain down or tighten the buttocks or the thighs. And you want to exhale and contract and keep your mouth open during a contraction being performed. So how do you perform it? So we're going to do that right now. So the good news is we're not in class and I can't watch any of you guys now. This was usually where things got a little uncomfortable in class because we were going to practice. The good news is now no one can see you. And what you guys didn't know is the whole time I've been sitting here, I've been doing Kegels. Have you noticed it? No. Right? Because very rarely can you notice when somebody's doing this. You're going to pretend like you're trying to avoid passing gas or holding a bowel movement by tightening the pelvic floor muscles. You want to concentrate on contracting the pelvic floor muscles up and towards the back of your back. Right? The one thing you don't want to see is your belly do one of these. You're contracting the abs. You don't want to see your butt raise up like this. At that point, we're contracting the butt, right? We're doing glute sets or ham sets even. Virtually, there should be virtually no movement in the butt. Now, sometimes when people start doing Kegels, occasionally you'll get this, right? And that's because they're contracting so hard that they're not isolating that pelvic floor, right? So in women, you're going to think about when you're doing this, the mid aspects of your vaginal opening should move closer to your abdomen and a closing feeling should occur. For men, a proper contraction should move the base of the penis close to your abdomen and your testicles should rise. If you can feel that happening, you're actually able to get a proper Kegel. Right? If you can actually get the kind of the basic feeling of the vaginal closing, or if men, most of the times the biggest thing they feel is the testicles rising. If you can get that feeling, you're moving on the right process. So what we're going to have patients do then is, okay, do one contraction of that. And I usually have them talk to me while they're doing it, because if I have them talk to me, they're doing what? Breathing. Yeah, right? We don't want this. What's that called? What maneuver is that called when they do that? Valsalva, right? And that's literally the opposite of what we want to happen, because Valsalva is the pooping maneuver, is what I call it, right? That's the poop maneuver. We want the opposite of the poop maneuver. We want the no poop maneuver. We want to be able to hold in whatever we're holding, right? I'm sure everyone tried that. No one was just completely sitting there staring at me like, I'm not doing this, Mr. McKeever. They actually do teach. Oh, hey, you know what? I mean, are they teaching it properly, Eric, or are they just kind of haphazardly doing it? There's my answer to that. No, right? It's just like anything else. When you start off, don't start off doing stuff like that. We're going to talk about weightlifting with Kegels in a second. We're going to talk about that in a second. So hold that thought there, Erica. So standing, you're going to stand with your feet about half shoulder width wide, tight the pelvic floor as if preventing to pass gas. You're going to form 3 sets of 5 daily, holding for 10 seconds. So let's think about this real quick. If we're doing 45 reps all day, right? That's 450 seconds of reps during the contraction, 450 seconds of reps during the hold, right? So 450 plus 450 is how many seconds again? 900 seconds. Divide those 900 seconds by 60. You're talking 15 minutes of exercise a day. Can we find 15 minutes? If it keeps you from being urinary incontinent? Yeah, right? You literally could spend 15 minutes of my class sitting here doing pelvic floor exercises, and really I would be none the wiser. Because unless you're doing one of these, I'm doing pelvic floor exercises. I don't know that you're doing it. And it does help things. For seated, you're going to seat with your knees apart, tighten the pelvic floor, uplifting the pelvis, but not the buttocks off the chair. Perform 3 to 5 sets, holding for 10 seconds each. Supine, lay as comfortable as possible, preferably hook lying, knees apart, and tighten the pelvic floor. So we're going to do all of these. And I put this on here because now you've got a nice little exercise set, maybe. And I've had this before where I've had people in here that say, yeah, they'll message me after. You don't usually say it in class, but say, hey, I've got some of this urinary incontinence and I didn't think about doing this. Thanks for at least showing us this, right? Now, obviously, if you've got a family member that they want to get eval, right? Get checked out, but still these are exercises you can teach pretty easily. And, Erica, you can teach your sister how to do it without the weight. So additional exercises you can do. You can do it while walking. This one probably is one of the hardest ones that for people to do, because for whatever reason, our brains get really messed up when we walk. You hear the theory people can't chew bubblegum and walk at the same time. Well, walking and doing Kegels can be difficult, but if you can do that, you've got some pretty good control. During urination, once a day, when I'm working with patients like this, I tell them you want to completely interrupt your urine stream. This is hard. For those of you that are thinking, oh, this seems easy, try it. Start a full urine stream and then stop it. So you're going to go full on and then just stop. Hold it and then start it again. Right? Well, what that tells you is your pelvic floor is not quite there yet, but this is going to be a pelvic floor exercise we do with them. This is 100%. If you can stop your urine stream, you're starting to build up your pelvic floor. No way. And then after urinating, so if you're done urinating, then you're going to take and do a couple Kegels. Some of you are like, yeah, it's easy. Okay. Some of you are going to do Kegels in order to further empty the bladder, right? If we've got a patient that maybe has urge incontinence, this would be a really good one for them. The worst is when you pee outdoors and someone walks by. Exactly. All of a sudden you're like, oh, this is awkward. I'll never forget. I had a hunter in Pennsylvania that we were working on. He actually came into the regular clinic, and it was the PT said, oh, hey, can you work on him with some pelvic floor exercises? And he had the same idea there, Dylan, except he said that he was out hunting and a bear walked by when he was going to the bathroom. He said, if you want to be awkward, you know, a person walking by is one thing. A bear stopping to watch you pee is another. I don't know what I'd do at that point. It's like, that would be barely scary. Or very scary, maybe. All right, so these are some of the devices we can use. These are biofeedback devices. Do you remember biofeedback from modalities? Or do you at least remember the term? I'm seeing nobody, so maybe not. Term, okay. So biofeedback are where we use electrodes, right? And as a contraction happens, what does it do typically? Has anyone ever used biofeedback? Could record it. Yeah, we can record it. It beeps. There we go, right? So the louder or the faster the beep, the more active the contraction. And we can set thresholds, right? So maybe the patient's got a fairly good contraction. We'll raise that threshold for beeping, so they have to activate more of the muscle. So that in order to get it to beep, it gets a little harder, right? We can do the same thing here, right? On this right side here, where's my little annotator? There it is. On this right side here, we have external electrodes that we can place around the anal sphincter and around the pelvic region to get a signal when they're doing pelvic floor activities. And then on this left side, those are not external pelvic floor testers. Those are internal pelvic floor testers. Or actually the one I think is an external by squeezing between it. I'm pretty sure this one is one that you actually just put between your legs. It's been a while since I've seen these, so don't quote me on it. But this one's definitely an internal recorder that it's going to record your actual contraction while you're doing pelvic floor activities. And now some of you are definitely, AJ is definitely going nope here, but again, these are what's going to help people. These are vaginal dilators. Stupid, there's no such thing. Unless it's about like the FBI, then I can't answer it. What's the stupid question, Renee? Oh, you're typing it, never mind. Good question. We still can use these. Yeah. Yep. And honestly, depending upon, yeah, well, they do make some of those as well. Here's the deal. So the problem with that, with going up the ureter of a male, is you're not going to ever get to the pelvic floor. Right? That's way up there. It's too far of a distance. And if you get up there, then it's more of a catheter than it is something to help that, right? But there are other things that they make these, so we can use these anally as well, right? They make different versions of them, obviously. The other thing that they have is they actually have an electrode sensor that you can place kind of a cage around the testicles. That when I said one of the things that happens when males contract the pelvic floor is the testicles rise. Well, that means there's a muscle pulling them upward. And that means there's going to be electrical signals, so that you can actually detect the electrical signal through testicles as well. Just remember, and this goes for males and females, if we are using electrical pads, what do you have to get out of the way? Hair. Yeah. So, well, butt cheeks too, maybe. Yeah. Right. But you have to have clean skin to make good contact. Right. So be aware of that. Yeah. And Renee, if you're wondering if that's awkward, absolutely, if that's what you're wondering. So these, again, vaginal dilators, this can be, for multiple things. So this can be used for pre-pregnancy and stuff like that, especially if we know that baby is going to be larger. It can help with that. I can comfortably say I have never used any of this, but I just want to make sure that they exist. These are vaginal weights and cones. These are kind of a new activity that are coming out. And there's actually, for those of you that this might be a problem, there's a new company out there that's, there's a new company out there. It's pretty rare that you guys make me crack up. You just did. That's okay. It's pretty rare that you guys are get me to the point where it's like, yeah, okay. I'll try to remember. I'm trying to remember there's a new company out there that actually makes a pelvic, or not a pelvic, a pelvic floor, a biofeedback device that actually syncs with your cell phone. It's Bluetooth enabled that you can get. That way you don't have to go to a doctor and get stuff like this, because most of this stuff is going to be prescriptive device type ideas, but they're now getting a little bit more common. But same idea here. The vaginal weights, just like Erica said with patients, trying to do Kegels and CrossFit while they're lifting weights, this would be the more appropriate way for them to lift weights with Kegels, Erica, is to actually physically lift a weight with their pelvic floor. I'm pretty confident if you ask the people at that CrossFit gym to do this, none of them are going to volunteer. But this would be a way they could actually truly lift weights while doing Kegels. This does, and actually this makes more sense to me than most, like the vaginal dilators. I still, for whatever reason, my brain just doesn't wrap around. The biofeedback I've seen used, and I've observed it being done. I've never done particularly that myself. External palpation, yes, I've done. But this makes sense to me, right? Because if you watch a weight raising and falling, that gives you visual feedback, right? And we know as human beings, we are visual people. Same reason why biofeedback works is if we can see a bar of the contraction and we can hear that beeping, we can associate it with what we're supposed to be doing. So all these tools work out kind of stuff like that. It makes sense. All right, now that we've kind of embarrassed AJ to the fullest, there are all kinds of devices out there for this type of stuff. So, and you got to understand that just with the fact that this is a burgeoning market, right? Honestly, pelvic floor is a really kind of new up and coming, not only physical therapy, but medical health doctor, field. And so just like anything else, when that stuff type happens, when we start focusing on one thing, is that going to attract the snake oil salesman? For sure. Right? It is. And when I say snake oil salesman, I'm talking people that are just going to sell you, here's some ashwagandha root that helps with urinary incontinence. One of the other things that we don't talk about a lot, and I still have to include it in this lecture, I didn't, is with men, what's one of the major problems that we might run into as men that women don't encounter in the pelvic floor? What type of issues? And maybe some of you ladies know. What's the one thing that we have that women don't have down there? Other than testicles, but testicles are technically ovaries, just on the external part of the body, but prostate. Yeah, right, the prostate. And for any of you guys that are in here, prostate cancer is huge. Like, not only does it get huge, but it is huge. And I know that, one of the things they say is, I think it's once you get over 40, they want you tested. I think it's yearly or every other year. I can't remember which it is, but don't skip out on it. I know that the test for prostate cancer is not exactly what you want to experience, maybe, or maybe you do. But it is pretty big for them. If they can detect prostate cancer early, it can be treatable, but it can affect your whole life, right? This can affect your urinary incontinence. Most times that it will affect overall function in general. You lose urinary incontinence, you lose sexual function, stuff like that. And that kind of brings me to the last phase of pelvic floor health is sexual physical therapy, which is another market that's starting to actually, no, it's not a proper, it's starting to take off. I think that's politically okay. So what type of stuff would patients or could patients have that could limit their ability to have sexual intercourse? What type of physical therapy conditions? Other than pelvic floor issues, obviously. But what other stuff that we'd encounter in the physical therapy world could limit their sexual function? Okay, erectile dysfunction, yep, good. And that can be from a multitude of things, right? When we think ED, we typically think that it's a testosterone problem or something like that. But man, there are so many different things that could cause erectile dysfunction that it's not even funny. It can be completely psychological. And there's nothing we can do in PT to fix that, right? But erectile dysfunction is one of them, good. What if I have a total hip replacement? Could that affect sexual? Oh yeah, think about that once, right? Especially what happens if you've got maybe an anterior total hip replacement, ladies, and you're limited on external rotation. That changes things a little bit, doesn't it? And guys, same thing, right? If you have one that limits you on an internal rotation. I know this is kind of a subject that we don't think about, but it can be problems. What about a total knee replacement? Could that somehow affect it? Yeah. Right. So these are the things we don't think about. Even something is like a reverse shoulder, total shoulder, or a rotator cuff repair, right? Because when you think about it, any surgery I have, they're probably going to give me pain meds. And pain meds mess with libido. And depending upon who you are, those pain meds can mess with your libido either way. Some people, the pain meds knock out their frontal lobe and their libido goes through the roof. Some people take the pain meds and it just knocks out your libido entirely and you don't even have it. And whether we like it or not, we are a reproductive species. Whether we're actually performing reproduction for reproduction or performing reproduction for pleasure, we are a reproductive species. And there is a certain amount of psychology that goes into that, right? For those of you that are married or thinking about being married or never want to be married, this may be one of the reasons why, who knows? Sexual intimacy is one of the major problems in marriage, or one of the major things that cause problems in marriage. And now, so maybe, the wife had a torn labrum around her hip and she went in for surgery, and now comes out and now it's uncomfortable to have sex. Is that going to cause marriage problems potentially? Yeah, right. I'm not using, it could be just as well the guy as well. I'm just trying to kind of come up with one solution, one type of idea here. So that's another kind of burgeoning field in physical therapy, is looking at how to help improve the sexual function and teaching patients what's okay during sex and what's not okay during sex, right? Because, I don't know how many of you know this, but there are multiple different variations of having sex. I know that this was an eye-opener to me too. I thought that there's pretty much only one type of sex and that was it. I just learned that no, I'm just joking. You guys are a hard crowd today, or this is really uncomfortable for some of you right now to have Mr. McKeever talking to you about this. Tyler's like shivering in his seat. But it can be really difficult, right? Also, if you've got a male that is having sexual dysfunction, he is more likely to reveal that to a male therapist, right? So maybe he's talking to the PT and the PT's female, and he doesn't reveal everything to her. And then he goes and works with Tyler and he's like, hey, this is affecting other things as well. And Tyler's like, well, what do you mean? He's like, well, I'm having erectile dysfunction. And then Tyler's like, but they're more likely, the same thing with females. Females are more likely to reveal this to female therapists, whether it's PTs or PTAs. So this can be and we talked about this in spinal cord injury, that actually is a sign of a serious low back problem, right? Do you remember that? Whether it's, sexual dysfunction with either males or females. Do you remember what that low back problem was called? Cauda equina syndrome. Do you remember that? Where the cauda equina is being pinched back there in the spine. That's the one that they complain about saddle anesthesia on the inside of their legs. They have problems with urinary output, and then they also have sexual dysfunction. That's a sign of the cauda equina being pinched in the low back. And when that gets pinched in the low back, that can definitely cause problems. And they're not necessarily always going to report that to opposite sex people. It is the horsetail thing. You're exactly right. That's cauda equina, horsetail. Spinal cord injury patients. Are we going to, I think pretty much guarantee, so I was going to ask a question, but I'm actually just going to say it. When we have spinal cord injury patients, especially completes, this may be one of the things we work a lot with them on is pelvic floor stuff. If they have still some functioning pelvic floor. If not, we may have to teach them that they don't have a functioning pelvic floor anymore. So we have to work with them on understanding when it's time to cath and when it's not time to cath. Now, we don't actually have to do the catheterization, just to put you all at ease. That's not something in our scope of practice. But we can talk to them about when it's a good time and getting on a schedule for catheterization so that they can make sure they're avoiding their bladder on a regular basis. And remember, when we talked about spinal cord injury patients, we talked about the fact that, for the most part, is it men or women that are more likely to have sexual dysfunction after a spinal cord injury? Right, men, right? Why it doesn't affect women again? Well, because women's sexual dysfunction or women's sexual function itself, now not the pleasure of sex, just reproduction, right, is hormonal driven, right? Your eggs are there, as long as your hormones are flowing, which is controlled by, all the glands in your body and stuff like that, right? As long as those are functioning, you can have normal intercourse. But a man, in order to have normal intercourse, has to have some form of an erection. And if there's no sensation, that's going to cause problems, right? And so men are more likely to suffer from sexual dysfunction with spinal cords than not. This is a lot of stuff, right? The good news is, are you going to get questions on vaginal dilators on your boards? More than likely not. Okay, so don't totally freak out about that. I put that on there as kind of informational for you so you understand kind of the stuff that the tools that are in our toolbox. But in reality, when we're working with patients, the biggest tools we have are Kegels and following the breadcrumbs to figure out what the actual problem is. Because we may chase it down the road that it's stress incontinence and then find out later down the road it was actually urge incontinence the whole time. And we've been doing the wrong thing. That's when we change up our plan of care. Right? Go, okay, well, this didn't work. Let's go over here. Pelvic floor should work with almost, and this is something that the APTA was, there was a poster presentation, I think at Next last year, but the pelvic floor group or the pelvic floor kind of silo of the APTA was talking that anyone over 60, when they come in for regular physical therapy, should probably have some training on doing Kegels, on doing pelvic floor health. Would that make sense to everyone in here? That anyone over 60 should get some pelvic floor training when they come into physical therapy? Could that prevent down the road them having to use briefs? Sure. Right? If they get their pelvic floor strong, because there's not a lot of muscles down there. It's not like they have to be doing pelvic floor weightlifting. What they have to be doing is managing and taking care of it. So what are your questions going to be on the boards? Well, definitely some of the questions are going to be on incontinence. So you definitely are going to have to know the difference and the types of incontinence. That's one of the big ones I can tell you does come up on the boards. Knowing the difference between, urge versus stress versus functional. And then also kind of being able to tell who is going to experience those type of things, right? Is it going to be, older patients, younger patients, what kind of diagnosis? Parkinson's going to be more of that functional incontinence where they can't get to the bathroom, right? So that's kind of important for understanding that. Are there any questions on today's topics? Was this uncomfortable for you guys? For some of you at least? No? Okay, good. Could have been worse, right? I try to make it as, I'm not going to bring videos and stuff like that in for this. That's not what I need to do. But there are plenty of videos out there. But when you're working on this type of stuff, it can be really important. The most important thing I can tell you guys when working on this, and the most important thing that the therapist that I replaced is they're like, treat them with respect. Right? And, you know, I've had some patients come in with urinary incontinence that joke about it. Why do you think they're joking? It's a coping mechanism. Right? That they joke about, well, you know, when you have urinary incontinence, you're in trouble. It's a coping mechanism, right? They know they've got a problem. They don't know how to fix it. They don't even understand their problem. Sometimes as simple as breaking out some diagrams on the pelvic floor and explaining what the pelvic floor looks like, right, can be useful. Most of the times they're not going to have pain in the pelvic floor, right? This is one of the times where probably asking on a scale of 0 to 10, 0 being no pain, 10 being the worst pain, how's your pain level today? They're going to go, I don't have pain. I just have pain in the butt with the fact that I've got urinary incontinence. So we may have to change up that. Rather than getting a pain scale, we may have to say, you know, on a scale of 0 to 10, 0 being almost no accidents and 10 being way too many accidents, where would you rate your urinary incontinence over the past couple of days? Oh, I'm a 5. Okay. And what seems to have been causing most of those accidents? Is it getting up? Is it sneezing? Is it coughing? That's giving us breadcrumbs, and we can follow those breadcrumbs to the source. All of you guys, when you graduate, are going to, you know, once you graduate and you get licensed, are all going to become mini Sherlock Holmes. It's going to be elementary, dear Watson. Your job is sometimes going to be to follow those breadcrumbs. Now, are we diagnosing as PTAs with those breadcrumbs? Nope. Not at all. Right? But we are going to take and work on following those breadcrumbs and providing our PT with those breadcrumbs through documentation, right? Through speaking to our PTs. And sometimes that can be awkward because sometimes talking to our PTs is hard. I've had PTs before where we didn't get along, you know, or we just had a difference of opinion, but you get over that and you get professional about it. So that covers the urinary incontinence, pelvic floor type stuff. One of the questions I also get when getting prepared for the boards is, what about endocrine and GI? How many of you guys would be worried about endocrine or gastrointestinal questions on your boards? Eric says me. Yeah, those are kind of areas that endocrine definitely, right? Endocrine's one that scares a lot of people because endocrine's like, oh my God, there are so many hormones and neurotransmitters and all this stuff that I don't remember what they are and where they come. The good news is, again, let me reach down here. Oh, I'm getting old. Your book has most of the stuff for endocrine. But when you look at, let me bring up the breakdown real quick. Hold on one second. Give me 1 second here, because we'll wrap up here in just a few minutes, so don't totally freak out yet. Where is this at? Journey map might be what I'm looking for. No, it's not what I'm looking for. That is not what I'm looking for. Give me 1 second here. All right. Why can't I find? There we go. That's what I'm looking for. Content. There's the content map. So let me bring this up, open it in PDF here real quick. So let's look at the content from your boards, just so that you can kind of see what you're looking at. Go over, and let's share this. This will kind of be where we finish for the day. All right, can everyone see the content outline I've got brought up there? Okay, so this is looking at items based upon what they're described as. So if you look at this, cardiovascular systems, you're going to have about 6 to 8 questions on data collection, right? You'll have about 6 to 7 on patho and 9 to 11 on interventions. And if you look the whole way down, interventions is probably one of the largest subjects, right? Well, that makes sense, doesn't it? Because we are intervening and helping patients. So when I get down here, let's look at GI. Right, here's my GI. I didn't want to draw a line through it. Oh, I thought that was going to highlight it, but I was wrong. Good job, Mr. McKeever. GI, 0 to 2 questions, 0 to 2 questions, total 0 to 4 questions. Does that make you feel a little bit better? Right, so at most on your board, you'll probably have 4 questions on the GI system. What kind of stuff do you think might come up in GI? What kind of conditions maybe? GERD, good, yep. Diarrhea, because that would come up, because that could impair physical therapy, right? Any type, GERD is kind of acid reflux and everything together. Swallowing, right? Because that technically classifies as a gastrointestinal. So something like a patient with aphasia, where they're having difficulty swallowing from maybe a stroke or a spinal cord injury, technically that's a GI question. When you actually go in and you look at your score builders book, your GI section is like non-existent. I mean, it's there, but it's not very large. It falls in the other systems category, which is kind of like everything else. Genitourinary, well, we just covered 0 to 2 questions, 0 to 2 questions, maximum of 4. I can deal with that, right? Endocrine's probably the one that serves the most questions on. If you look at here, so we can have a total max of about 7 questions. So that one is a good one to get a little bit worried about. So what should you do for that one? Go back and review your neurotransmitters, right? So go back and review what does the pituitary secrete? What does the, oh my God, why did I just draw a blank on glands? What do the adrenal glands secrete? What do the testes versus the ovaries secrete, right? Those are the type of things you're going to encounter on your endocrine stuff, where it's going to be looking at the endocrine glands and remembering what they do, right? Technically, if you have a pregnancy question, they're talking about relaxin. Technically, that's an endocrine question too, because that could go in there. So 5 to 7, when I look at that, I go, I can live with that. Lymphatics, 3 to 6 questions. That actually has gone up. It was only like 1 to 2 questions before, but we've now got so many people coming in with chronic swelling that is important. That you might get questions on low stretch bandages. You might get questions on how to clear lymph ducts, meaning that you start from the proximal lymph ducts, clear them, and then you clear the lymph. You might get a different question. A good one that I've seen before and I've had a question on is knowing the difference between primary and secondary lymphedema. You guys remember what the difference between those two is? It's okay if you don't. It's okay to admit you don't remember it. That's what we're here for. You remember what the difference between primary and secondary lymphedema is? Okay, thank you. Somebody admitted to it. Okay, good. primary lymphedema is where lymphedema is the problem we're dealing with, right? So whenever we see a primary versus secondary, it's caused by the lymph nodes itself, right? Secondary is something else caused it. That's a great question, actually, for all of these, right? So if I get a question maybe about GERD, primary GERD would be caused by the stomach actually having the problem with either proton pumps being kicked up, stuff like that. What could cause secondary GERD? What about positioning? Could that cause secondary GERD? Burns could, yeah, okay, right? Diet technically would be secondary GERD, right? Because it's not caused by the stomach at that point, it's caused by what you're eating, right? If you're constantly eating Robertos and you're getting GERD all the time, maybe it's time to consider cutting back on Robertos. And then system interactions are where we look at multiple systems working together. So that's where, how does the neurosystem interact with the musculoskeletal system? I wanted to bring this up because I wanted you guys to see, when you look at this, here is the bulk of your test. Is that the bulk of what you learned? Right, it makes sense too, right? Yeah, definitely, Dylan. The bulk of your test is going to be cardio, musculoskeletal, neuro. And whatever test prep course we're throwing at you, a lot of the focus is going to be on cardiovascular, musculoskeletal, and neuro. Because if I can get you to nail all of these questions up here, if you miss a gastrointestinal question, it may not affect you. Because most of the gastrointestinal questions I've seen, and again, this is anecdotally, this is not proven by scientific evidence, but most of the anecdotal questions, most of the questions I've seen from kids that have come back, and I call you guys kids because that's just what it's not a term of endearment, guys. I call you all kids. Come back from taking their test is really level 1 questions, right? What does this neurotransmitter do? Where does the esophagus lead to? It leads to the stomach, right? The flow of food through the stomach. Could you guys do that? Or the flow of food through the body? Where's food enter the body at? Hopefully. Oral cavity, right? Goes through the oral cavity, goes down through the what tube? I just said it a little bit ago. Esophagus. Passes through the esophageal sphincter into the stomach. The stomach begins the breakdown process, right? The stomach emulsifies a lot of it, right? That's where a lot of our churning happens. Passes out of the stomach and goes into which intestine? Not the specific name, but which set of them? The large or the small? You sure it goes through large first? Poquito. Yeah, small intestine first. Because large intestine is where you're eventually going to evacuate it, right? So it goes all through those miles of small intestine, right? And then it comes over here to your ascending large intestine, goes across your transverse large intestine to your which large intestine? Descending large intestine, and it eventually exits the body via the external anal sphincter. Any of those would be a valid question for GI. Right? Question for something like metabolic and endocrine would be, how would antidiuretic hormone affect the body? Or ADH. It says it in the name. It's an antidiuretic hormone. Yeah, not peeing, right? Fluid retention. Whereas, guess what they're going to get for that medication-wise? They're going to get a diuretic, such as Lasix or something like that. Could be something dealing with what's the gland that sits right behind the chest bone? Thymus, right? What happens to the thymus as we get older? Yeah, it shrinks, right? It starts out really large when we're a baby. It gets sad and shrinks. Yeah, it causes it in itself, right? Okay. What condition dealing with acetylcholine can get thymus problems? I might leave that and see if we can get it as where they might give them anti-acetylcholine that we might have talked about in neuro. I might leave that one to see if you guys give you some homework to go and look for it. I might just, he's like, it's on the tip of my tongue. I can feel it. I can see it in his brain. Myasthenia gravis. There we go. Good. 2 points to Gyra. Unfortunately, this is whose line is it anyway, and the points don't matter. Good. Right? That would be a metabolic question that ties to a neurological condition. So those kinds of things you're looking at. And then if you go down here, these are considered non-system questions. Equipment and devices and technology. Therapeutic modalities. Safety and protection. Asterisk here. Myasthenia gravis. So myasthenia gravis is the condition that can cause the thymus to have problems where they may have to do a thymectomy, where they get a thymoma. We talked briefly about that. And that was also an acetylcholine disease. I just tried to tie it back to what I was talking about the thymus. Yeah, no problem. That's back. And that's back on the sheet I gave you, that cheat sheet for like myasthenia gravis, Parkinson's, all that. It's back on that sheet if you need something to review. Now, looking at this, equipment, devices, and technology, therapeutic modalities. So you might have 20 questions total on that, on equipment. Not bad. Most of the equipment question, honestly, you guys should be able to get. I'm going to be honest, right? Depending where those cheat sheets. Yeah, I do. I know it's not a cheat sheet. Got him. Safety and protection. So here's the deal with safety and protection. When you see these 4 to 6 questions on safety and protection, they are not tied to any disorder. So this would be what happens if you give a patient a burn, right? This would be calling a code if a patient's having a heart attack. Those are the pure safety questions. You will have safety questions, and I've said about before with neuro conditions, cardiac conditions, and stuff like that. These are going to be pure safety related. Professional responsibility. What do you think some of those would be? I know Dr. Reskin, HIPAA, good. Yeah, HIPAA's a big one. Dr. Reskin talked about one yesterday with 6 months, not doing what? Not dating your patients. Yeah, not sexting your patients either. And I'm going to add to that caveat there, just to let you guys know, don't date people you work with either. It doesn't go well most times. I'm just gonna tell you. Yeah, I know. I'm just gonna tell you from coming from my old age, you don't want to date somebody that you work with. Life is just like Grey's Anatomy. No, it's not. It's more like Repo Wars than Grey's Anatomy. And then research and evidence-based practice, 2 to 3. I cover that heavily because most of the time that's the one you forget about. But I mean, looking at this, it's not as bad as you think it is, right? And there's all kinds of things. And this breaks, I can actually post this so you guys can look at it. But this breaks down what's in each of the sections. Looking at that breakdown, does that make you feel a little bit better about how the test is designed? That you're not going to get a lot of obscure stuff, right? Yeah, good. That's kind of what I had a couple of you email me about. That's why I want to kind of cover it before I let you guys go today. All right. So I am pretty much done. Are there any questions, even about the boards, about getting licensed, about anything I can answer?
Yes, I do.
Yes, AJ. I had to figure who it was.
Our past class stuff, like the Blackboard stuff, how long does that stay like available to us to be able to, like, do we need to start pulling stuff off right now? Like when we graduate, it's gone? Or
that's a really good question. That's a really good question. I don't know. I can find out for you. I don't know how long you have access to it. I know it eventually goes away when you graduate, but I just don't know how long it is. I'll talk about the final in a second. I don't know how long that's up there for. So
yeah, thank you.
I can find out. That's a really good. Honestly, believe it or not, AJ, no one has ever asked me that question, so I don't know the answer to it. All the cohorts, no one's ever had that. Lab tomorrow. Yes, we have lab tomorrow. Definitely. I'm going to actually stop recording now real quick because we're pretty much done with class.